So next is Boerhaave Syndrome. It's V4. So you're called to see a 23-year-old male in the ED who has had severe episodes of forceful vomiting in the last few hours. He was attending a party and smells of alcohol. There is no background history. He is complaining of severe chest pain. On examination, he is clearly distressed, dry retching each time, bringing up streaks of blood. He is tachycardic, 112 beats per minute, with blood pressure of 152, oxygen saturation of 98% on room air, and temperature of 37.6 degrees. How would you manage this patient initially? So in line with the ATLS protocols guidelines, I will administer high flow oxygen, gain IV access, send all his blood, FBC, UNEs, coagulation, LFTs, amylase, CRP, lactate, cardiac enzymes, and arterial blood gas, and I will start intravenous fluid. Then I will do 12-lead ECG. I will do erect chest X-ray and analgesia. The X-ray reveals pneumomediastinum, buzzword, pneumomediastinum, and his white cell count is 22 per liter. How would you proceed? The clinical picture and investigation are highly suggestive of spontaneous rupture of esophagus, which is called Boerhaave syndrome. And this is historically described by the Meckel's triad: vomiting, chest pain, and subcutaneous emphysema. Due to high mortality and associated with the condition, the early treatment must be initiated while further confirmatory investigation is undertaken. Early management involves the use of broad-spectrum antibiotics, antifungals. Don't forget about antifungals. Keeping patient nil by mouth, intravenous fluids, placement of urinary catheter for accurate urine output monitoring, and further observation in the high dependency unit or intensive care setting. And to confirm the diagnosis, we should do a CT thorax and abdomen with oral water soluble contrast. A CT thorax and abdomen with water soluble contrast confirms the small leak in the lower thoracic esophagus and associated 2 centimeter adjacent fluid collection. How would you proceed? So decision for further management depends on the 4 factors. Number 1 is the patient clinical condition, hemodynamically, degree of esophageal injury, integrity of esophageal mucosa, adjacent to the injury, and the risk of surgical intervention. In most patients, an upper GI endoscopy to visualize the injury, assess the integrity of adjacent mucosa, and degree of intervention is safely done by expert hand. The treatment is aimed at minimizing the mediastinal contamination and allowing healing of primary injury. So if a healthy patient and overlying and remaining mucosa is healthy, the contamination is short duration, the primary repair is gold standard. This can be done by left thoracotomy, and which allows for good control of sepsis by cleaning the mediastinum. The aim is to debride all necrotic tissue and suture repair the defect. A T-tube can be used to create a controlled fistula. The repair can be buttressed by non-circumferential flap of pleura or muscle. A conservative approach, number 1, gold standard, surgical repair. Number 2, conservative approach may be adopted in a stable patient with very small injury and minimal contamination. This involves appropriate broad spectrum antibiotics, antifungal, nutritional supports, nil by mouth, and drainage of medicinal collection in the form of drain or chest tube. Number 3, esophageal stenting is becoming more prevalent in recent years, especially for patients who are unfit for any major surgery. This involves the placement of fully covered stent over the injury, administration of appropriate antibiotics and antifungal, nutritional support, and drainage of intrathoracic collection in the form of chest drain. And the 4, if there is extensive esophageal injury or unhealthy adjacent esophageal tissue, with the precludes primary repair, esophagectomy and the formation of esophagostomy may be indicated and can be life-saving. The timing of the intervention is vital, as delay in the treatment can increase the mortality and options in terms of management. It is essential that Boerhaave syndrome should be managed in specialist center with appropriate support, as there is a high mortality regardless of the management. Now, if an esophagectomy with the formation of cervical esophagostomy is performed, when and how can intestinal continuity be re-established? So re-establishing intestinal continuity in this patient is quite difficult because of the previous adhesions of the sepsis in the mediastinum, and I would therefore wait for at least 6 months from initial recovery before considering an attempt to restore the intestinal continuity. It is of utmost importance to optimize the patient nutritionally, and intestinal continuity can be re-established with using the conduits, and the choice of conduit depends on previous surgical history, patient condition and length required. Option include the stomach, colon, and jejunum. So number one is the tube formed by the stomach. Number two is colon. Number last is jejunum.